This is QD Clinic, and I'm Dr. Jack Cush from RheumNow. QD Clinic is brought to you by RheumNow Live, the little big meeting. Little because you'll be one of 150 people in the room rubbing elbows with the faculty. It's not like those gigantic meetings where there's 600 people or 15,000 people and you get lost and don't know what to see or do. It's a big meeting because you'll be with big time faculty and have some big time opportunities to exchange meaningfully with them. It's also going to be big, and that's going to be streamed over the internet to a larger audience. This week we're discussing the EULAR guidelines or recommendations for the treatment and management of rheumatoid arthritis. Yesterday we went over the overarching principles, and today we're going to start with the 12 recommendations and cover the first 3. So number 1 begins with therapy with DMARD should be started as soon as the diagnosis of rheumatoid arthritis is made. This is sort of a no-brainer, but yet there still are a lot of patients who have the diagnosis of RA or are entertaining a diagnosis of RA in whom symptomatic disease management is occurring. If I make a diagnosis of rheumatoid arthritis or have a strong suspicion and I'm going to order confirmatory labs, the patient leaves the office with a prescription for methotrexate or another real DMARD. And that may be tailored up to maybe multiple therapies. Again, you can always stop them at any point. The gravest mistake in managing RA is to not be aggressive, not diagnose early, not institute treatment early. I kind of like my EMR for the one simple fact that if I have a diagnosis of RA and the patient isn't on a DMARD, my EMR is asking me, why is the patient not on a DMARD? And I think that sort of makes sense. You don't wait. You don't sort of wishy-wash about, well, let me just see how they respond to nonsteroidals or low-dose prednisone, or let me use some hydroxychloroquine because I really can't make up my mind here about whether this is or isn't rheumatoid arthritis. Either you're in or you're out. Either symptomatically management and call it undiagnosed inflammatory arthritis, but once you put a label of RA, MO5.79 or MO6.1 or 09 for seronegative, you need to start DMARD therapy. Again, to have RA and not be on a DMARD is to not have RA. Recommendation number 2. Treatment should be aimed at reaching a target of sustained remission or a low disease activity state in every patient. This is a carryover from the 2016 recommendations. It makes a great deal of sense. I think you want, obviously, to have a T to T attitude. Treat to target is strongly advocated by EULAR. They have recommendations on treat to target and its benefits. I think that it doesn't matter what target you're going to use or what tool you're going to use. You need to use the tool and treat to that tool. So again, ACR guidelines with EULAR, I think, said that CDI is preferable. But it could be SDI, it could be Rapid 3. I use a GAS score, which is patient pain, HAQ score, and their pain level. Pain, HAQ score, and tender joint count. It actually turns out to perform just as well as the CDI score, which is probably the best correlated with the -28 ESR. Nonetheless, it doesn't matter which one you use. A goal of, in the case of CDI or GAS, of LDAS, low disease activity state, of 7 or less, or remission of 3 or less is what you need to have. If you don't get there, then you need to move on. The question here are the time frames. The time frames are actually critical. They say here that if you're not getting there, let's see now, if you're not getting there within, that's the next guideline. So again, use these treatment guidelines to get the best response. Use the tools that you have, these validated tools on assessment to achieve your target. Now, everybody should be going for remission, but sometimes a low disease activity state is prudent, and that would be patients who already have damage, where because of their damage, because of secondary degenerative change or periarticular disease, you may not get to a very low score, but you may get to a low enough score to indicate that they're in a low disease activity state. The third and last one we'll consider today is monitoring should be frequent in active disease, meaning every 1 to 3 months. If there is no improvement by month 3 after the start of treatment, you need to be changing your treatment. Or if you don't achieve your target, let's say a CDI of less than 3, by 6 months, treatment should be changed, adjusted, whatever you need to achieve your goals. So they're putting a 12-week limit on the attainment of improvement, and they define improvement as at least 50% improvement in TJC and SJC. I think these are a little too lax. I think with many of the drugs we have now, you should be getting better in 2 weeks or 4 weeks. And I would say 6 weeks is really where you need to be making changes, but that's the Jack Cush recommendation on management, not the EULAR recommendation. They do go on to point out that rapid attainment of a selected target endpoint is now regarded as being the most critical of sensibilities you need to employ here. There is evidence that says that if you don't achieve this rapidly, that if you don't achieve at least a 50% reduction within 3 months, the probability of reaching the treatment goal of remission is low. So you do need a rapid response. Rapid responders are people who are going to have fantastic responses to the drug you're using. If you're getting a so-so slow response that takes 12 weeks, 16 weeks, maybe 24 weeks to get to the goal, well, how good is that therapy going to be in the long run? Again, I think you really need to think about that. These guidelines are being laid out in sequence and in accord with the idea of starting out with someone with early RA and new changes to therapy. It conforms to the algorithm that they use and is on the website and in the paper. That's it for episode number 2 of EULAR recommendations regarding the management of rheumatoid arthritis.